So this is a case actually we did, Dr. Khalid Tammam and myself, as in a preparation for Middle East session in Japan. And at that time we were struggled, what case should we do in Japan? Then we chose this case that is very complex, epicardial channel. So we'll start with this. This is the, let's go with the case. Is a 55-year-old gentleman who had unstable angina, LAD, territory is hypokinetic, is 55%. Let's say this is the view, this is the main view showing the collateral here. Let me see. I can play it. And he was trying to get this CTO intervention 6 months prior to our intervention, Khalid, or?
He tried several times, antigrade. The last one was 6 months before we start.
So this is the channel, this is the only channel we find going, feeding epicardially, feeding the LAD. And the RCA injection showed this. So it's heavy. What's going on? No, I need it to be moving. No, it's moving here. That's not moving. The picture is not moving. So you looked at the picture. Let's discuss it while we are doing here. 55-year-old with good ejection fraction, hypokinesia in LAD territory, has been unstable angina. This epicardial vessel, as you see it, tortuous, and the RCA showed no collaterals. We'll show it to you. So go 40 seconds, please.
That's until it's open. Who's in the audience starting again antigrade to this patients? So he has been trying several times to doing a antigrade, which is the same stump and was filled. So if you have these patients, so who's starting again to do the antigrade? So can you raise the hand? Antigrade, retrograde, sending the patient to surgery.
Yeah, Khalid, I think the most important is to know how it's been done. I mean, you need to know what kind of wires did they use.
Yeah, it was a stiff wire.
Was it done by expert operator or not? And then the other thing is what happened, what stopped him, whether dissection was not. So you have to look at the films to decide whether you can try again or not. But I think always you should have the option, depends on what have been tried and the way it's been tried. So you cannot really decide from the beginning that one trial, you should not try again from the antigrade approach.
Okay, so basically he was trying to cannulate between the diagonal and the septal, this area, and stopped. It's here. Look at this channel, this little nipple here. This is the trial at that time. The nipple between the diagonal and the septal.
And sorry, was cabbage discussed at all with this patient or no?
Yeah, patient was refusing the cabbage option. I think the cabbages will be very good option, one lima single graft, and that finish. But patient was refusing the cabbage option at that time, as usual.
So, can we discuss right now? So, what is the cabbage is out?
We didn't see the collaterals from the right. Was there any collaterals?
No, there is
from
no
the right?
collateral. The collateral only ipsilateral. There is no retrograde from the. So now we have this kind of collaterals from epicardium collaterals, which is when we use, we have to put in mind the time of ischemia, the complications from the epicardium channel, versus send patient to surgery, versus try again with a different technique. Maybe Julian will show us the stingray, but at that time we don't have even these options in our cath lab.
Patient was symptomatic? Patient was symptomatic?
Yeah, CCS2.
Basically, if he is symptomatic and he was fishing around with after optimal medical treatment, apparently he had optimal medical treatment.
No, we let's decide. We're going to fix it. This is CTO session.
Of course.
So how can we fix it? So
Yes, you can go through this ipsilateral channel, either by two guides, ping pong technique in the left system, or bigger French. You can go 8 or 9 French to do the same by one guide only. A question to Dr. Khalid. If you will do from circ like that, usually if you do circ epicardial collateral to the right, you cut short, you shorten your guide. This one, I don't think it will need to be shortened. So?
Usually it's when you, yes, sometimes if we have externalizations of the guiding, sometimes it will be good. And if we have a short guiding, but this guide is very tall, and we don't need to make it short, the guiding.
So we to save time, we used only one guide, EBU 357 French. So the going with the channel we showed you initially, this is a Corsair, this is a Sion wire with this tortuosity. At that time, there was no the new microcatheter wire. There was no dedicated epicardial guide wire. We're using only the Sion. So the trick in this case is how to negotiate these tortuosities. At the beginning, of course, we have a pericardiocentesis kit available in the lab. Just it's there. We just open it whenever we, and the patient should know this risk. The tortuosity here needs to be straightened out. Injections, minimal time, minimizing the time of keeping the wire in. Just we avoiding the ischemia and LED territory. This is the principles we ran to it. So the Corsair is going through it. We're waiting for straightening these curves. And multiple injection to make sure we are not in the little side branch. So from this microchannel, from this epicardial collaterals. So who has experience in the dedicated epicardial guide wire? Did you use it, Osama?
You're talking about the SAW 3? Or
Yeah.
what? Yeah. For the retro, it's not here available. I don't think it's yet available.
It's not registered yet in
It's
Saudi
not
Arabia.
yet available in this. But it's not really, even you can use it for difficult retrograde, so you can use it for whatever you need. But the good thing about it is the tip is
So if you notice, we're going back and forth to the guy to make sure, yes, now straightened. So we're waiting for this moment that's straightened. Then we inject just see if there is no perforation. And one of the other signs, if the guide of the microcatheter is dancing away from the heart, that we are in the pericardium. Alhamdulillah, it was not. We injected, it was not. So now we're going toward the easier part, toward the LAD.
Isn't it safer to use fine cross in epicardial collateral than Corsair?
I think the crusade is more easier, and it's because sometimes it's dilated when it's going. It dilates the small. Of course, Carabel now is the best. So, but we don't have still Carabel is available. So, crusade is the best one to go with the epicardium. But we have to be sure again because it's very easy to have a perforations if you have a very tiny small epicardium channel. So we have to be very careful all the time to don't have any perforation, because the perforation in this large pericardium is usually is fatal. So it's we have to be careful. So
was there any PVC's pattern? That's
That's
something that
very
you
good point.
usually see with the usual CTOs, particularly with these wires.
So this is really very good points. But if you see here, we're having PVCs when we are going toward that nipple. Look here, when we're going to that nipple, we have PVCs. We're going up north, we don't. And if you think about it, there is no such vessel from LAD that's going north. If we think this is the LAD straight line to here, there is no way there is a branch going this way. If there is a branch going this way, diagonally. So we thought this is, this most likely, this is the track and the nipple is a false track coming from the previous trial. So here, after we got to this point, we exchanged the Sion to the Miracle 6, then Confanzia Pro, and it was very hard to know where is the LAD. We wish we didn't do CT. Khalid?
yeah, I don't want to tell the case, but
Did we do
no,
CT?
No.
Okay.
No. If we did the CT, the patient can be done very easy. So,
Okay.
but because the patient has a lot of radiations, and a lot of exposure of radiation last 1 year, so we'd like to minimize and we know this procedure will be very long, and the contrast will be very high. So we'd like to minimize the radiation and the contrast to not doing CT.
Look, Dr. Osama Hadrami. So when we go north, there was no PVCs. When we go south, there was PVCs. So despite south, we thought south is the right way to go, but it's going this way. So we inject, it's going this way. So maybe this is the LAD, this little one, we think it's the diagonal, maybe the LAD. So we thought it's a joke. Let's go move ahead and to the antegrade to make sure that the nipple is the LAD or not. So we went antegradely, this point, trying to track this little thing, and there was PVCs. Every time we touch this nipple, PVCs.
So it's very important that if we try even antegrade again, it's not going the same. So the promising entry point we see it from antegrade is not a true lumen even.
Have you tried IVUS?
IVUS with antegrade you have to dilate. So no probe of IVUS will go without dilating the first. You mean putting the wire in the side branch and try IVUS?
In the side branch, yes. Just
Which branch?
We don't have a branch. It's the only small septals, and the IVUS cannot go there.
So we finally reach an agreement that this is a nipple of a false track from that previous trial. So it shouldn't be the true channel. This one, there is no way to be a branch. It's gotta be an LAD. No way to be branched from LAD, and it's going smoothly in this track, going that way.
Wait,
No.
just a quick question. When you were trying the retrograde, did you use like a Fielder XTR or something like this
Of course,
instead of a stiffer wire?
we start with we start slowly.
Yeah.
So first option after Sion, we start with filter XTR, and then it's not working, so we going, because it's the CTO segment need to have penetration wires. So penetration wires only going from Miracle 6, Confianza Pro 9, or Gaia. But at that time, we don't have Gaia in our cat lab.
Yeah, I don't remember if we used Fielder XT. I think we Miracle 6, then Confianza.
Yeah, but even filter. So can you move, because the timing it's
Okay.
so can
Okay.
you
Whenever we see Dr. Waqar around,
Yeah, of course.
heart rate is up. Okay. So now, let's go with we went with ultimate guide wire, trying to kiss both.
No, it's yes.
Trying to this one. This is the ultimate. Trying to get through, and it went through. I don't know where it is. It went through to the septal branch. So that means we are in, and then the vessel externalized. After externalization, pre-dilatation balloon, then with using 1.5 balloon to make a channel for another Corsair. We got another Corsair here, but we be careful with another Corsair, they can lock. So we have to have a space between the two Corsairs. Then we took out the RG3 wire and we inserted just regular wire, then pre-dilatation balloon, then stenting. No, actually before stenting we did IVAS. I'll show you the IVAS.
So we was about to do a reverse card techniques in this case, but unfortunately the ultimate's going easy to the true humans. So from beginning we are in the true humans. So the tips in this case that the LAD has a acute curve.
So let's finish this. So the trick in this case, the previous procedures can create false channels. Epicardial channels need to be straightened in order to be crossed. Watch always for the danger of tamponade. So, and again, I disclose this case was made so challenging to be presented in Japan in 2013 or 14. Thank you.